Okay, so here we are. So once again, we reached out. We wanted to know what everybody was most interested in. And the hot topics were, surgery in advanced stage cancer, oligometastatic disease, which is, again, using local therapy, radiation, and/or surgery while you're still on a systemic therapy, leptomeningeal disease, and liquid biopsies. So those were the hot topics. And what I'm going to have the panel come up here, and they'll quickly introduce the topic, and then we'll start the questions. I have a few questions, but then we'll do what we did earlier, and we can go around and ask more questions. So our experts, our Hollywood for this session, please come up. I think you met everybody. The only one you didn't meet is my amazing radiation oncologist, and he'll introduce himself.
Hello? Are you guys able to hear? Okay. I'm Gaurav Marwaha. I'm a radiation oncologist here in Chicago at Rush University. Thanks so much for being here, and it's an honor for me to be here too.
Okay, here's the objectives. Our speakers. LMD, leptomeningeal disease.
Okay. So we've talked about how frequently lung cancer, EGFR mutant lung cancer in particular, goes to the brain, and how important it is for our drugs to get in there. Sometimes we can treat the brain with drugs and not with radiation, for example, or surgery. But most often, these metastases are little spots within the brain that can be radiated with stereotactic radiosurgery, and we have a radiation therapist on our panel. But sometimes the cancer leaks out into the space around the brain and starts to coat the surface of the brain, involving what's called the cranial nerves, like the optic nerve and the nerves that control the motion of your eye and the sensation on your face, and then often down the spine as well, because it's all connected. The fluid around the brain is connected to the fluid around the spine. And once the cancer gets into that space, that's a really dreaded complication. And I've had patients that have disease control everywhere except there. And it's really an extremely difficult type of development to treat. And the major treatments are, in the medical, trying high dose or pulse dose therapeutics. There are some intrathecal approaches that are being tested, some cell therapeutic approaches, but also radiation approaches, what's called craniospinal radiation. And particularly, it seems to be effective is proton craniospinal radiation. But all of these things are suboptimal, and we need better therapies for this disease. So we can talk about questions people may have about that. Then we'll go oligometastatic is radiation, I guess.
Yeah, pass the clicker. Do you have a clicker? Okay, yeah. All right.
Pass the clicker.
Okay, so I'm going to talk a little bit about oligometastatic disease. I am just going to show this slide first, because I think even for me, when I was learning about what this meant a little years ago, this was a helpful schematic. So we all know there's localized cancer that may just be in the disease site organ of origin, the lungs, for example. We know about widely metastatic disease or polymetastatic disease, which we can see cancer that's spread from the lung throughout the body, including areas like the brain, bones, adrenal glands, liver, really anywhere. But there is this sort of spectrum between localized disease and widely metastatic disease. And that's where this specific term oligometastatic disease lives. There have been various definitions for this, and a lot of clinical trials will use a certain number, whether that's 3 or 4 or 5 sites of metastatic disease. Other trials more recently have kind of gotten away from the total number per se, but may reference things like the number of organs involved or the burden of the oligometastatic disease. So in terms of definitions, probably 3 of the most common definitions we see in practice. So oligometastatic disease is that presentation, so the presence of relatively few sites of metastasis at the time of diagnosis. Then we have something called oligopersistent disease. So patients will start on systemic therapy or drug-based therapy, and then over time we find that many of the sites of metastases have resolved or improved, but there may be some that have persisted despite those treatments. And then there's oligoprogressive disease, which these are areas that have grown or new areas that have popped up while patients have been on targeted therapy or other kind of systemic therapies. So we can see sort of, even within this space, there's a lot of different variety based on the definition we're using. When we counsel patients, we refer to, at least I like to refer to the burden of the cancer. In other words, it may not be the number, it may not be which specific organ, but it might mean what are you feeling as a patient, how is it impacting your day-to-day life, and that actually may actually play a bigger role in terms of our definition of, is this something that we should be aggressive with from a local therapy standpoint or not. So we are kind of living in a very exciting time because there's been a lot of research recently suggesting that we could potentially build in local therapies as part of the treatment paradigm from the beginning. And so a lot of times what happens is patients will start on systemic therapies or targeted therapies, and we'll get a scan, usually a few months down the road, and we'll kind of look and see exactly what's left, what if there's anything left, or if there's anything new, or is everything resolving, and then we have a conversation about building in local therapies as a mechanism to maximize progression-free survival and maximize symptom-free survival and so forth. So in my world, as a radiation oncologist, one of the most exciting tools we have in our arsenal is stereotactic body radiation therapy, which is sort of the American acronym SBRT, and then worldwide it's more often referred to as SABR, or stereotactic ablative radiation therapy. And really all this is kind of fancy terminology for using a very high dose of radiation delivered to very precise areas over typically 5 or less total treatments of radiation. And why we like this so much, particularly in oligometastatic disease, is that it minimizes interruption, if any, to a patient's otherwise ongoing systemic or drug-based therapy. There are other ways we can deliver radiation over a longer period of time to larger areas. Those oftentimes may require an interruption in systemic therapy, for example, and may not be as well tolerated as a kind of more focal ablative approach like SBRT, but it's another one of our tools in our arsenal. Oops. Let's see here.
So evolving role of surgery. So into disease neoadjuvant. So in the past, and there's actually for a while there's a lot of debate whether, if there is a patient with the lung cancer and then the lung cancer has spread to the lymph node in the mediastinum, this is what we call N2 lymph node, is there a role for surgery? There was a hot debate among medical oncology, radiation oncology surgeons whether surgery is required for that or versus different chemoradiation. I think with newer data now with the Checkmate 816 and Keynote and everything else, I think that debate actually is settled. With a single station N2 lymph node, otherwise healthy patient, I think our recommendation will be to give some sort of induction treatment followed by surgical resection. Let's say that there's N2 disease is much more progressed. So we now the terms are becoming multiple N2s or bulky N2s. So if it's a really bulky lymph node that are multiple, then I don't think there's a whole lot of debate among surgeons, medical oncologists, and so forth, whether surgery is required or not. I think those patients have a fairly poor prognosis. In general, those patients probably will undergo some sort of a systemic plus or minus radiation treatment. It's the multiple station N2 or single bulky lymph node that are much more in terms of debate. So actually, it's a funny thing that this actually came up because we just actually came up with a consensus among our Thoracic Society. We did this thing called Delphi process along with medical oncology and radiation oncology, commit to some sort of consensus of what to do with N2 disease. For single station N2, especially let's say a patient with a high PD-L1 score, I think in those kind of circumstances, I would think that single station bulky lymph node patient most likely will undergo some sort of an induction treatment followed by surgical resection. As also the multiple lymph node. There is actually an ongoing trial now called LungMate 013, kind of looking at this. Patient will undergo induction treatment and then will be separated out to surgery versus radiation. Shows a fairly actually remarkable response with the induction followed by surgical treatment. So we'll more know about it as we get more information, and then the paradigm as how to treat these will change. Currently, right now, we discuss about whether you're going to do a surgery or not at the time of the presentation, meaning patient present with the big lymph nodes and stage 2 or 3 or 4 cancer. But that may change in the future. Patient may just get an induction, sort of a systemic or targeted treatment. And depending on the responses, they may get triaged into surgery, radiation, or further medical treatment. So it's a very exciting time in our life now, because now with these newer drugs out there that are really having a very remarkable responses, the role of actually surgery has actually expanded to go beyond just the early stages, but much more advanced cancers. And then duration of the adjuvant treatment, that's I guess $1 million question. And I think there's an ongoing trial now looking at how long whether those patients with N2 disease, you did inductions, did a surgery, and then they're all gone now. There's a question of whether to give a adjuvant treatment or not. I know they have designed a trial right now and they're occurring. But let's say the patient has a persistent disease, right? Do you give it or not? Or how long? Those are a lot of questions that has not been answered. So I do think that it's in general for EGFR mutated cancers, I think 3 years after resection. But for persistent disease, that might be a lifetime, right? So there's a lot of unanswered questions, and hopefully in the future with a lot of clinical trials, we could answer these things. And the utility of surgery as a local therapy, I think, is a part of a consolidated treatment for oligometastatic or oligoprogression. I think there's a lot of phase 2 trials already answer that, versus just a maintenance therapy alone. Local consolidated therapy for stable disease has shown to be beneficial. And so just figuring out who are the right patient I think given the fact that both radiation treatment and surgery is a fairly safe option. I did mention in the past, like, what is the advantage of surgery? Because radiation is fairly minimally invasive or non-invasive, right? But surgery is invasive. But the benefit of surgery is that we actually get tissues so that we may know better molecular profile of the tumor. And then we're able to completely remove those lymph nodes too. So in that sense, we could get a better prognosis and maybe tailor future treatment after that.
It's really fun to watch the radiation oncologists and the surgeons go at it.
No.
I'm kidding. Go.
No,
Go.
but I think we're very collaborative.
You are. I'm
and
joking.
I think
Go ahead.
surgery and then radiation is more complementary than adversarial, in my opinion, because there are things that I would say they help us, and then I help them too, because there are some patients who get a definitive treatment, and then they progress on that. So, for instance, patient has a healthy otherwise, stage 4, but had a systemic and great response, and then had a local radiation treatment. I have treated a patient that actually after definitive treatment grew, and then my oncologist, radiation oncologist said, hey, Sam, can you help me with this? And vice versa, there's a patient that I operated and that has a local recurrence and may benefit from SBRT. So I think it's a complementary
I was joking. So, I mean, it's kind of a fun joke, but.
Yes.
Yeah,
okay.
no, but and I don't want to take up too much time because we want you guys to be able to answer questions, so.
Can I just clarify?
Yes.
Clarify one thing. The word neoadjuvant means treatment before surgery. And a lot of what was just said related to neoadjuvant immunotherapy for driver-negative disease. You would never consider neoadjuvant chemoimmunotherapy for EGFR mutant disease. And it's being tested with the targeted therapies before surgery, but that's not approved and not
correct.
shown to improve survival yet.
Yes, so there are ongoing trial called NeoAdura, NeoAlina. Those are for the patients with a positive EGFR mutation or ALK mutations. But that has not been approved because we don't have data whether that's beneficial or not. So those patients with the EGFR positive mutation patient, we would give an induction chemotherapy or chemoradiation followed by surgical resection.
Okay, click.
Did you talk about?
Oh,
we covered it. We can get here.
Covered
Let's see.
it already earlier.
Oh, well, this was. Oh, okay. This is. Oops. All right. Now, all right. So I'll try to be brief because we want to get to the interactive discussion parts of this. But I know liquid biopsies. This is an important topic. There are different types of liquid biopsies of blood tests here, okay? And they tell us different information. They have different potential roles. And it's important to note that different forms of liquid biopsies are currently part of standard practice, and others are really more investigational. So this first line here is, well, what's the difference between molecular circulating tumor DNA and minimal residual disease testing modalities? So by and large, in clinical practice, molecular circulating tumor DNA, these are tests like your Guardant test, your liquid Tempus test, your liquid Caris test. They're looking at finding the mutations, kind of analogous to what you're doing in the tumor. We will sometimes do these on treatment to see if these levels are changing, or to see if there's progression and how the molecular profile is shifting. That's what really the circulating tumor DNA tests are looking to assess. Minimal residual disease is very different. That's not looking at profiling and looking at the EGFR, or now is there a MET, or these sorts of things. It's looking at what is the smallest level, the most microscopic, minute level that we can detect the cancer in the blood. There are two forms of doing this. One is called tumor-informed, where actually it involves profiling the cancer and then creating a barcode, you could think of it as, for the unique patient cancer to try to, again, see what that looks like at the smallest possible level. And then there are so-called tumor-uninformed strategies that are looking at various signatures of the cancer and, again, trying to monitor those at really the most smallest level. Now, where will that have potential applications? And I say potential because, again, this is not part of routine care. Where I potentially see that is skipping ahead to the third line is therapy intensification and de-escalation. And really where I see that playing a future role is in the adjuvant setting after either surgery or definitive chemoradiation, where we don't know how long does someone need a treatment. Can they stop this treatment sooner? Once they stop it, can we monitor? And if we start to see that again, should we then restart the osimertinib in that setting? Now, again, I'm postulating all these as research questions, things that we need to determine. This is not standard care yet. Now, doing that in advanced disease, much trickier topic. Because if we're talking about advanced cancer where, while we want to cure, obviously that's the ultimate achievable goal, but where we can't oftentimes achieve that with our current strategies, if you do a test like MRD and you see numbers going up, do you act on that or not? If someone is tolerating a treatment well and we're not seeing any macroscopic evidence of cancer growth, meaning we don't see on scans that something is growing, is there a utility to changing up the treatment sooner, to introducing new side effects sooner, or is this just what we call a lead time bias where we're getting this kind of before down the road we're going to see something appear on a scan? So that's the main differences. And then again, I think we talk about baseline profiling. I think that, primarily plays a role in routine practice with the circulating tumor DNA and looking at the profile of the cancer, doing that oftentimes together with the tissue biopsy profiling so that we can get the answer sooner. And that's also the test where we talk about profiling at resistance, where we talk about, all right, now that we're seeing cancer grow, we want to assess profiling of the tumor, but also of the blood so we can get the most information we can to make a treatment decision. And I think these are just some schematics. I don't know how much this necessarily adds to the discussion, but just saying how we can use circulating tumor DNA and MRD that's on the left about like, can we escalate therapy, can we de-escalate therapy, and on the right is just a schematic of, again, how we profile these tumors. And I think, this is a figure actually that I developed for a discussion at World Lung. I think this is when we're talking about blood tests, these are the key pillars we have to keep in mind, okay, for any new test, and for any test for that matter. Is it feasible? Is it reproducible? Is it clinically meaningful? And then the fourth answer there is, will it actually impact what we do? What I talked about, the MRD testing, this minimal residual disease testing in someone with advanced cancer. All right, we can reproducibly detect that. We can see that it's changing, but will it impact what we do, or will it just introduce more anxiety into the situation? And unknown. So I think that's the extent. Yeah, now we'll switch over to the Q&A.
No, that's a great point. And, I just want to point out, too, not everybody's cancer sheds into the bloodstream. So, a lot of times you cannot get information from these tests. And yes, they're becoming more and more sensitive. But like what you're talking about, too, finding them, and that's especially true like in the early, people with less tumor burden, like not so much disease or earlier stage disease. So now we're talking about finding it like in the most micro, so they have a long way to go to develop, but I think more importantly, that's a great slide you just showed, like what do you do with that information? But okay, so we have a few questions, and so we'll ask that, and then you can raise your hands. And again, we are going to try to get the rest of, I have pages right here of questions that need to be answered, and we'll try to get those back to you. Okay, first question is, if you have progression, and this is to you, Gaurav, if you have progression, how do you know when it's right to switch your therapy or whether or not to use radiation?
So I think this point has kind of been emphasized a little bit in when Sam talking too, but the importance of multidisciplinary management for all our patients is absolutely critical. So all of us at our respective centers have a forum where we sit down with our colleagues on the multidisciplinary team, and we review every scenario and have a conversation about, what would it look like if we change systemic therapy or augmented systemic therapy, or we added local therapy? Was it local therapy something surgical? Was it something radiation? What type of radiation? So we have these conversations. I always talk to patients, say, you know, your ear's probably ringing because we've already been talking about you at our tumor board at our conference. So that's a really, really critical opportunity we have as physicians to get input from all the perspectives at the table. That being said, you know, there's nothing hard and fast to say, okay, if there's a certain number of metastases or a certain size of metastases, but you know, most of our patients are being very carefully monitored, generally every few months with CT scans, imaging. And so, you know, we'll look at areas that are growing, and, you know, if something's moving very, very slowly, you know, at least in the radiation world, you know, we don't get too excited until it's over a centimeter, for example, when we think about bringing in local ablative therapy. And even in that scenario, if it's something that's moving very, very slowly, you could kind of push a local therapy down the road a little bit further. If from one scan to the next scan there's several new areas, or multiple areas in one organ, or a number of other clinical signs or symptoms that our patients are having, then we may be looking more at changing systemic therapy, or also building in radiation, what we call more of a palliative, a way to kind of relieve a symptom, or maybe there's something obstructing or something bleeding. Radiation can have a role in that respect as well. But it's hard to kind of say exactly what size or what number or what locations. But I will say that as time has gone on, and particularly in the SBRT space or the SABR space, we're less concerned about where in the body. We actually feel pretty comfortable treating metastases virtually anywhere. And we've actually experimented with reducing doses, especially when we're treating multiple areas, as a way to help patients tolerate things better. And those are some opportunities that exist, and we're excited whenever we can do things that can kind of maintain the current systemic therapy.
So just a couple of other issues. I mean, if the progression is in a previously radiated area, if it's ultracentral or in the mediastinum, it's difficult to do the high-dose radiation. But also, it depends on the medical options. The patient's on fifth-line therapy, and there's no good medical therapy to switch to, you're more likely to use local ablation.
And then other things for a guy who's providing local control. If I get referral and patient has a progression, the question is what kind of progression, right? If patients start to develop much more nodal disease, then that's more a systemic disease than local control issue. So if there's a multiple lymph node that is being developed on systemic treatment, that patient probably will not do well with the surgical resection. They'll get through the surgical resection, but they'll continue to probably progress on the nodal disease, which is more systemic. On the other hand, if a local progression is just where the tumor is getting bigger, then that patient probably will likely do well, because that means that whatever the lung nodule or lung cancer is pretty resistant to whatever the systemic treatment is, then we could provide a local control for that. So it depends on what is progressing.
Yeah.
That for me is more important.
Yeah, no, that's a good point. And again, it reinforces the importance of all the disciplines, talking, looking at it, and really of what's important and meaningful to you, what do you want to do as well, and talking that over. And again, I feel like it's that strategy. It's getting to that next first down, and waiting for research to catch up as well. It really is a game of strategy now, and I think, we've heard a lot about incomplete or conflicting data, so there are no concrete right or wrongs many times. Many times it's taking that data and applying it in the context of that patient and that family, and that's, I think more or less what they are referring to. The next question, doctor ordered a Tempus test. Can you please explain more of what that is?
Well, yeah, I think so Tempus is basically one of the companies that does next generation sequencing. So a lot of us, and our institutions included in this, we use commercial partners for our next generation sequencing. You can oftentimes get a result turned around quicker. I think there are advantages to it's almost like a one-stop shop. Well, they'll do the surface staining, some of the IHC staining for markers, the next generation sequencing, looking at the DNA, the RNA level. Some places have institutional assays as well, but really Tempus is just the name of the company that does that test, just like Caris, C-A-R-I-S, or Foundation. I think those are probably the three largest.
And they can do blood and tissue, or both.
Exactly, and Garden is just liquid, I will say, Garden is liquid, but they're developing a tissue test, just how Caris is tumor, and they've developed the liquid, so they're all kind of, but really, Tempus is just one of the platforms that gets that molecular information.
And some places have in-house, so you may be at an institution where they don't send it to a Tempus or a Garden or Foundation or Caris, that they may do it at your cancer center. That's also another.
Do you do in-house testing?
Unless we do in-house NGS for tissue, but not blood. We send out bloods. But the other thing maybe we should mention about blood testing is there's a new variable that they're reporting, and that's tumor fraction, which is really, really important because that tells you whether they actually detected any tumor DNA at all. Because one of the problems with blood testing is it's often negative, and you don't know whether it's negative because there's no tumor DNA or it's negative because there's no mutations. Right. But now they're reporting this tumor fraction number, and there's really good data that if you have a tumor fraction of more than 1%, you have very high accuracy, very high sensitivity. Less than 1%, it's more questionable. So that's something to be aware of in a blood test.
And to piggyback off that, I don't know if we can go down the blood test realm a little bit more here, but I think also with a lot of these expanded panels, it expands one's anxiety because you're trying to look at this now we're getting more and more genes, but is that truly relevant, right? There's a lot of what we call variant of undetermined significance, VUS, which means there's an alteration there. We don't know if it really matters for the growth of the cancer. We don't even know if that alteration is in the cancer. Your normal body cells, Christine, do you have something to add? Or did you? Oh, she. So that makes it hard to interpret, and now these are being reported when they're not validated on a lot of these readouts, and it can make it I think.
And blood tests can also detect mutations in blood cells.
Exactly.
It's called CHIP,
Yep.
which is a false positive.
Exactly.
So to add can you hear me?
Yeah.
To add another layer of complexity, can you comment now on how Guardant is also reporting percent adeno, percent squamous, and percent small cell in their clinical tests? Just so we see the full spectrum and understand, like, this is interesting. They're reporting it. Do you use it, and how do you use it?
Yeah, I can start, and I'll tell you, when I've met with that company about everything that's now reported for patients and providers to see, I take a little issue with a lot of these things now showing up on a report when they're not validated. There's no clear data there about how well this works, and there's no standardization. In reality, so oftentimes, right, we're cancer doesn't read a playbook, so sometimes there's what we call cancer of unknown primary, where there's advanced cancer, but we don't know where it started. And oftentimes it's hard to pinpoint that, and a lot of these molecular tests are trying to figure out ways to predict, all right, where did that cancer come from? And same to that adage, sometimes we do see mixed histologies of lung cancer where it has appearances of an adenocarcinoma and a squamous, and you have to kind of make treatment decisions, oftentimes in what chemotherapy you're utilizing. But I have a lot of trouble figuring out how to interpret that result. And again, I'm not really a fan that that's on the report.
You use NGS to determine mutations. You use light microscopy to determine histology.
But you know what to do with that mutation. So if you get that information,
sometimes, unless you get 52 different mutations in genes you've never heard of. But the other thing blood tests can do is determine germline discover germline mutations. I had a lung cancer patient recently that had, on a blood test, 50% allele frequency of BRCA2, which is the breast cancer gene, but this was a lung cancer patient, and she did okay on chemo-IO for a little while, but then I tried her on a drug called olaparib, which is a drug they use for breast cancer BRCA2 patients, and she had a beautiful, durable response. So and then she did some family testing, and it found out that she had this gene in her family.
So sometimes if your report comes back and you have something like a 50% allele frequency is what it's called, your oncologist will refer you to genetic testing. We don't have a lot of information on, again, remind you that the EGFR gene or mutation we're talking about is not in your DNA, it's in the cancer, everything we've been talking about.
Not usually.
Not usually. That's what I was getting to. But last night I mentioned T790M, but and there's a lot more research going into looking at if there are other, hereditary factors. But so that's definitely something to talk to your doctor about if you have any concern at all.
Just to clarify, I'm not sure if we really explained what allele frequency is. When everybody has 2 copies of most genes, except for on the sex chromosomes. And if sometimes there's if there's a difference between the 2 genes and you sequence them, half of the sequence reads will be one gene and half will be the other, and that's called a 50% allele frequency. And when you're looking at tumor DNA in your blood, usually these variants they're detecting are at very low level. So they will call a variant allele frequency of X%. So if you have a P53 gene that's normal in your genome but mutated in the cancer, and they detect 1 out of 50 reads in the sequencing is mutated, that's a 2% allele frequency, and that's usually reported on these tests.
So maybe we should have a webinar on how to read the reports.
Well, I have to say, a lot of doctors don't know how to read the NGS reports.
That is true. You're right.
Actually,
But we
coming
should do
back
that.
to
We should be required to have PhDs in genetics.
Yeah, right. Well, that's difficult. Okay, do we want to open it up to questions out there?
Thank you. Is it on? Okay. So I have a few-part question here. So when do you think that MRD testing will be, ready for prime time? The other question is, when do you think that MRD could be used as a new endpoint in clinical trials, an MRD negative, like PFS and OS? Wouldn't it shorten clinical trials and bring stuff to the patient earlier? Because I know from friends, whether this gynecological cancer or whatever, even some lung cancer, some doctors will do MRD testing, now.
Yeah.
And maybe that should be a shared decision rather than just the doctor, not offering it. I don't know. So
I'll say so some of these tests are available. And I'd like to use an analogy that a neurologist said to me when I was a medical student. Ordering lots of tests is like picking your nose in public. You have to have a plan in place if you find something. And I just say that in the sense that, while we can order these tests, we have to know how to act on them. And I do think that, MRD has a lot of rational thought in terms of how it can play a role. In terms of a timeline, I think the good news is a lot of current trials are building those assessments into the studies, because that's the thing, it needs to be built in to get something to become prime time for routine clinical use and to be used as a biomarker, as an endpoint. It has to have validation, and there has to be clear validation, and same with as a surrogate for an endpoint. I mean, we don't technically pathologic complete response is, while that appears to be a surrogate, that's also, to my knowledge, is not a validated endpoint that's used to get approvals and things like that. So it's complicated.
You have to show that knowing that and acting on it improves survival. And the fact is, there's no MRD test in lung cancer that has shown that. And in fact, you could argue with EGFR, the standard of care is to continue first-line treatment beyond clinical progression. So why, if you're taking osimertinib and you have a Signatera test that goes up a little bit, would you switch to chemo or add chemo? I guess you could, and that's being tested, but that's never been shown to be any better than potentially that rise was caused by a single spot that's growing that could be permanently ablated with radiation or surgery, and you should stay on the Tagrisso rather than going to amivantamab or something second line. So it makes sense to use MRD to make decisions, but that has to be tested and shown that what your gut tells you is actually reflected in reality, because you're making significant changes to a patient's treatment with metastatic lung cancer. You really don't want to do that willy-nilly.
Because also the concept is not new. I mean, there's a cancer marker called CEA that we used to monitor, and and we don't make treatment decisions routinely based off of changes in CEA levels.
Well, and the other thing is the technology is changing every month, basically. And so an MRD test from last month could be complete. It could be positive this month just because they changed the technology and became more sensitive. And yet you'll say, oh, now it's positive, we should drop the therapy we're on, when actually it's not. It hasn't changed. It's just the technology has changed.
Yeah, I mean, if the cancer is progressing, that's clinically significant. It's going to show on the CT scan, PET scan, and so forth, right? And that's what we're relying on. Just because the number, for instance, colorectal cancer, CA went up, they're going to do a much better, thorough job of investigating if there is any local progression radiographically, but a lot of times they would.
But there are really good clinical questions that really could use MRD testing. Whether you use adjuvant or not, the presence of ctDNA after surgery is clearly a bad prognostic factor. It needs to be tested whether that factor, if you intensify adjuvant, you can improve the outcome of those patients. We don't know how long to treat with osimertinib after resection of EGFR. Suppose you treat a patient till they clear their ctDNA and then you stop. That may be good enough, and you don't need years and years of treatment. You may need 6 months. But that has to be tested with a hard endpoint, and I think we should be using more and more survival endpoints and not progression-free survival, because we really have to start thinking about improving survival here.
You kind of answered my question just then. So, but I did want to say, like you were talking before about how the levels were going up. But what if the levels were coming down and you were just having these blood tests to monitor like every 6 weeks and possibly like go down on treatment or know that your cancer is dormant right now?
Well, that would make you feel better, but would you change the, I mean, if it goes to 0 for 3 months in a row, I guess you could say you stop therapy, but I wouldn't do that with EGFR mutant disease.
So right now, like Tagrisso is kind of like a permanent medication for life, right?
Oh, the amount of ctDNA, you might use more intense therapy?
No, I was thinking that if the number goes down, that would you lower the amount of treatment or stop treatment for a while?
I mean, if the ctDNA goes away, you might want to, and the patient's having skin problems with Tagrisso, sure, you'd feel more comfortable about dose reducing, but I would dose reduce anyway if the patient's having side effects. So the bottom line is I don't use MRD testing at all outside of a clinical trial. And I know a lot of docs will send them every 2 months at a multi-$1,000 per test charge without any data. And you wonder why healthcare is so expensive in the United States. That and 3 2-month PET scans.
Hey.
Okay, good question.
Yeah, so that's a great question. So the question
Oh,
is...
the question was, what is the role of proton therapy versus photon, which is what is normally used?
Yeah, so proton beam is basically a different particle. So the majority of centers, cancer centers around the world use photons, which is X-ray based therapy. So this X-rays are used for diagnostic purposes to look inside our body, kind of crank up the noise on those. They can become therapeutic and they can damage DNA in cancer cells. Protons is a different kind of particle. It damages cancer cells the same way, but the technique in using protons, the potential advantage is that you're getting sort of what we call this blast of dose in a very focused part of the body, and virtually limited to no entry and exit dose of the radiation. So it could, reduce what we call collateral damage. So when photons go into a patient's body, they kind of go all the way through, and we can't avoid really anything. We've kind of sharpened our techniques, and we're doing better and better. But there's always going to be some entry dose and some exit dose of photons. Protons, they can kind of come in, have their impact, and then there's virtually no exit dose. So you can protect, critical structures, tissues in the body that are close to the area that needs to be treated. So one of the limitations is we don't have, not every place has proton therapy. The second thing is most of the research looking at proton therapy outside of pediatric cancers and scenarios where there's retreatments or kind of treating the same area with radiation for the second, third, or more times, most of the research has been not very exciting in terms of this is a huge benefit versus photon therapy. One of the things that was briefly alluded to earlier was cranial spinal irradiation for the treatment of leptomeningeal disease, or really extensive disease along the lining of the brain and the spine. There are some data that suggest, when you're treating that much area and you can limit the amount of radiation then that's coming through and out, exiting through the heart or the lungs, you could actually spare a lot of tissue. I think that's an area that's interesting. And we use that technique in pediatric cancers when they have diagnoses like medulloblastoma, for example. Young children, we want to, they're still growing. We want to protect, all of these structures in front of the spine and the brain. It does have a role. It's, when we look at SBRT, though, SBRT, at least technically, is a stronger option. There is a little bit of uncertainty, without getting into too much details, about protons. As good as we are at aiming with protons, there's a little bit of an uncertainty, a few percent uncertainty as to where that blast may happen. And that could be, pretty catastrophic if it happens in an area that, let's say the esophagus or the close to the spine, or some area that could have a really meaningful toxicity. And with stereotactic radiation, we use pretty razor thin, what we call margins, or the envelope around the tumor we're treating is really tight, and it's extremely well studied and extremely well tolerated. There are techniques with protons, we call intensity modulated proton therapy, and then you can ramp up the dose, but it hasn't been studied in comparison to SBRT or SRS in the brain, for example. But maybe in time we'll kind of learn ways to do it in a more safe way.
Hi, just here in the back. So I just wanted to, obviously the EGFR resistors, this is, at the end of the day, an advocacy organization. And, while I respect, the idea of, hey, listen, we need clinical validation. You guys are physician scientists. I would be remiss if I didn't push back a little bit as far as liquid biopsies and their integration into clinical practice. Obviously, I think, in the academic community, as was mentioned, there's these endpoints, or maybe not endpoints, but monitoring with serial liquid biopsies is being integrated into clinical trials. Shedder in particular, I think Helena Yu's trial, is looking at intensification, and I think that would be the direction of clinical development. I mean, correct me if I'm wrong, but there are, to acknowledge variations in clinical practice, certain physicians who do monitor with tumor-informed assays, which are exquisitely sensitive. And just with the point about showing up on radiographically, sure, but wouldn't you be able to guide your surveillance radiographically a little bit better if you're getting actual biological data about increasing tumor fraction? I mean, it's already well known that tumor fraction, shedding a lot, is increased with, or correlates with outcome. So, well, obviously to your point, this has not been clinically validated, but I guess just in terms of the advocate role, in terms of hey, how can we advance care for patients? I guess, could you give us a sense of what you guys are looking for, when you can bring this forward into the clinic and will be a part of routine clinical care? Is it something like Helena Yu's trial with Shedder being positive, and then maybe that's something, or just, I guess, if you could give any insight into what you see in terms of the future direction of integrating liquid biopsies?
Well, let me start by answering that. I think there are some situations where there is clinical utility of liquid biopsies, and I'll give you some examples of where I will use this. Again, with the caveat that yes, we're a data-driven world, but we do make individual patient-level decisions, and a lot of that has to involve discussions, with your provider on why we're ordering this test, what information is there behind it, and how can we inform our decision-making. I'll give an example. If I have a patient who has a scan, and suddenly there are some changes that just don't make sense. Now there's suddenly a bunch of new spots where there weren't previously. Maybe it's actually an infection, but I'm not sure. Well, oftentimes there I'll get a ctDNA analysis, a blood test, and if I see things are holding steady or they're actually looking better, I have some I feel a little bit better about that clinical scenario. Again, but that's me personally making a decision. That's a decision where I think there's utility to ctDNA potentially. I will say I have ordered MRD tests, for example, in the setting of where we're considering adjuvant osimertinib after a surgery. Let's say it's an early stage, 1B, where yes, this is approved, but some patients are really struggling with the decision, and I'll say, okay, well, if we want to get some other data point to help guide this decision, maybe there's utility there. Again, I say maybe because this is not something that's been prospectively validated. I still, though, have to say that in an advanced setting, utilizing that to assess tumor burden is a very tricky thing. If we get a test like that and something's going up, do we do a scan a little sooner? I think that's something that potentially could have a role to try to assess when are we going to see this microscopic progression turn into a macroscopic progression. But
then what would you do?
Exactly.
That's my question. And does insurance pay for it? I mean, you're talking about
for the ctDNA or the scan?
MRD.
Oh, the MRD. Yeah, the MRD.
So you're in an academic center. 80% of people are treated in a community.
Exactly. Well, now with a lot of these companies, because they are earlier on in their life cycle, they will eat that cost. They will actually cover any out-of-pocket expenses. But again, to your guys' point, it's not yet something that we know will make a difference for long-term outcomes.
There are trials going on that look at real hard clinical endpoints based on MRD interventions, and we have to wait for those, I think.
No, and I do think at the end of the day, you could have these conversations with your team, but also at the end of the day, their oath is do no harm. So, I mean, they're looking out for patients' best interests, and if there's nothing to guide, if there's no clinical benefit, that's why you have these conversations. And again, if you want the test, you can ask for the test. see what your oncologist said, but you have to understand the risks versus the benefits, because there are risks.
More is not always better. I mean, one thing you're tempted to do is, say, the rising ctDNA. You add more chemo or you add more treatments, and with the concomitant increases in toxicity. But time and time again in oncology, more is not better. We tried bone marrow transplants is more chemotherapy. That washed out in breast cancer, it washed out in small cell lung cancer. So be careful about doing logical things without clinical evidence.
And you know, just as a patient, I had surgery, adjuvant therapy, came back, I had surgery, and then nodules kept, were popping up. And at the time, the only drug was that Tarceva that they were talking about, and 9 out of 10 doctors thought I should go back on it, and there was no way I was going back on it. And so I actually used SBRT for 5 years, treated 3. I have no doubt, it is not easy to watch, but I really thought about the risks versus the benefits, and I wanted something in my back pocket. And as long as I could watch these and they weren't getting aggressive, then my thought process, again, it's getting to that next first out. I have no doubt if I would have gone on that, I would not be doing as well as I'm doing today, or God forbid, not be here today. So it really has to be a thoughtful conversation. And that might not have been right for somebody else, but the point is, reacting is not always the best way to go. Have these conversations with your team, and you will end up coming up with whatever is best for you. So I just stressing, advocate for yourself, learn more, but also just always think about what are the risks versus the potential benefits versus the potential risks. That is the most important conversation to have, because if the potential benefits are kind of unknown, and the risks are really low, then that unscientific, okay, let's, you make your choice. But if the risks are kind of high, you really have to think about, and that, again, that's the conversations with your team.
I have a question for Dr. Marwaha.
Yeah.
Yeah. So the chemo can be bad and the side effects can be miserable, but generally they don't last forever. A few do. I got some weird calyx. Radiation, my exposure through, not radiation exposure, but there's a little bit of damage in the lungs. But I've had other friends, unfortunately, with cancer where the radiation damage or side effects is permanent. My biggest anxiety is that answer is going to come back and the answer is going to be radiation, and my other friends, the radiation destroyed them. I know that that's not always the case, but help me get over that.
Yeah, no, that's a great question. So a lot of it depends on what part of the body was treated, how much dose it received, what era the radiation happened in. To give you an example, kind of switching gears to looking at a lymphoma, cancer of the lymph nodes, it's kind of a hematologic cancer. We used to treat these huge fields of radiation. I mean, it would cover both sides of a patient's neck and their chest, and we learned that that was too much. We didn't need that much, and we were actually driving secondary malignancies. As time has gone on, we've refined our approaches. We're treating a lot more, we use the word conformal in our world, which is maybe more focal. Our technology allows us to shape the radiation beam better. We've learned a lot more about how much radiation each tissue in the body can receive safely, and can receive safely again or again. Sometimes we're treating a second or third or fourth time. So we have a very careful, pros and cons or risk-benefit conversation with our patients, and it really comes down to where are we treating, how much volume is going to be treated, how much dose are we using, and actually, most importantly these days, what drug therapy is going alongside side by side, because that can actually sometimes sensitize certain tissues to have a more reaction to radiation therapy. But I think, depending on, the friends that you're describing, what they've had done, and, it could be a very different scenario than some of the techniques we're talking about here today.
So SBRT hardly has any side effects in general, but big field curative intent radiation to the chest in some people causes really devastating fibrosis, shortness of breath, and some of it's not predictable. And then when we're talking about radiating like adrenal glands or things that are near the stomach and the abdomen, you have a lot of nausea, vomiting. So, and a localized bone radiation can often be very effective at pain palliation with minimal side effects. So it's really dependent on the field, and it is different between patients too. So it's very difficult to say radiation in general is tough to take. You're an expert on radiation.
What time is this? Okay, we have like 2 minutes, so yeah. Can we get one more question, Brian, in the back? Yeah, quick. Literally 2 minutes.
Can you please talk about the pros and cons of CTs versus PET scans every 12 weeks in monitoring progression of disease?
So that's typically a medical oncology question, so maybe I'll take it. It's controversial. I see a lot of patients in my area getting serial PET scans. I do not use PET scans for routine monitoring for multiple reasons. One is that CT scans are often better quality. They're sharper, easier to do tumor measurements on than PET scans. Two, PET scans have about 20 to 50 times as much radiation exposure as a CAT scan. And when you get PET scan after PET scan after PET scan after PET scan, that's a lot of radiation. And somebody who's been around, is being monitored for 15 years, that you could get secondary malignancies from that much radiation. Third, it costs multiple times as much, healthcare dollars. Fourth, it takes hours to do rather than seconds. And fifth, I find it often is misleading because FDG is not a perfect indicator of cancer. I have seen patients that have FDG, the PET scan lights up during therapy, and it's just the immune system attacking their tumor, and there's no tumor there at all. So I think PET scans are not how I monitor metastatic disease. Now in lymphoma, it's different. They've monitored my lymphoma with a PET scan, and I think that's more rational. But in lung cancer, no. Baseline PET, and then PET if you have questionable findings on CTs and you want to investigate further.
What about MRI versus CT?
Of the brain? Well, certainly brain MRIs are much clearer than CTs for looking at metastases.
Yeah, I'll actually add, a thin sliced, contrast enhanced MRI of the brain is the standard. Anything that's not that, you're going to have a high risk of missing, early metastases that may be forming. That really should be the standard.
For liver metastases, sometimes they use MRIs a little more sensitive than CTs.
But the garden variety lung, I think I prefer CT over MRI. But CNS involvement, definitely, if let's say there's questionable liver involvement, right, metastatic liver, MRI tends to be very good. But overall, just a lung, lymph node, I think CT scan is most reliable.
All right. Well, thank you guys very, very much.
Thank you guys.